Hi, good afternoon. My name is Jessica, and I am going to be presenting this quality management project of preventing hospital-acquired pressure ulcers, also known as HAPUs. I'm going to start off with defining what a pressure ulcer is. So it is a localized injury to the skin and or underlying tissue, usually over a bony prominence, as a result of pressure or pressure in combination with shear and or friction. And this is defined by the National Pressure Ulcer Advisory Panel. Okay, so the first thing, the plan is to identify the issue. So not only is it an individual health organization concern, but is a national concern because of morbidity, treatment cost, and reimbursement issues. Stage 3 and 4 pressure ulcers are preventable. And in 2017, Centers for Medicare and Medicaid Services, also known as CMS, reported 257,412 cases of secondary stages, stage 3 and stage 4 pressure ulcers, and at a cost of per case of $43,180,000. There has been an increase of 86.4 of HAPUs from 1993 to 2006. In California, stage 3 and stage 4 HAPUs are mandated to be reported to the Department of Health. These stage 3 and 4 pressure ulcers are among the eight preventable conditions identified by CMS. Since October 2008, hospitals no longer receive higher Medicare payments related to the ulcer-specific care of patients who acquire stage 3 or 4 pressure ulcers during their inpatient stay. Pressure ulcers have been described as one of the most costly and physically debilitating complications in the 20th century. So to continue with this, pressure ulcers hamper quality of life, and prevention of pressure ulcer is an important goal. Hospital readmission rate is very high. To prevent, we must understand how they occur in the first place. So external pressure more than 33 milligrams of mercury occludes the blood vessels so that the underlying and surrounding tissues become anoxic, and if the pressure continues for a critical duration, cell death will occur, and this results in soft tissue necrosis and eventual ulceration. So leading contributing factors are prolonged pressure. Interrupted higher pressure requires shorter time, while continuous lower pressure will require longer time to cause tissue necrosis and pressure ulceration. Because of the effects of pressure, the ischemic degenerative changes occur at all levels simultaneously, affecting the skin, the subcutaneous fat, muscle, and fascia, if any, between the bony prominences and the pressure causing surface. So continuing with identifying the issue, it is also important to know contributing factors that form pressure ulcers. So pressure, what is pressure? It is the perpendicular load or force exerted on a unit area of the body. Pressure equals body weight, skin contact surface area. Muscle and subcutaneous tissue are the most susceptible to pressure-induced injury than the skin. Therefore, pressure ulcers are generally worse than what they appear on the skin surface. Reperfusion after relieving the pressure leads to inflammatory tissue destruction by macrophages, also participating in the cause of ulceration. So shearing and friction. When the body glides with gravity over a surface, the skin and the subcutaneous tissue remain stationary, and there is a differential movement of the underlying soft tissue like muscle and fascia. The forceful intertissue plane movement causes stretching and tearing of blood vessels, reducing blood flow, stasis, and ischemic tissue necrosis. Loss of the stratum corneum, the breach in the barrier against infection, occurs when friction between the skin and the stationary surfaces such as beds and clothes occur. Repeated friction may lead to deeper injury by underlying tissue ischemia, and risk for infection may occur. Moisture is another factor. It's intrinsic moisture from perspiration, urine, feces, and discharge causes maceration of the skin surfaces, weakening the skin barrier and making it more susceptible to pressure, shear, and friction, promoting ulceration. Position of the patient. Changes in body posture generate pressure at different anatomical points in the body, making them susceptible to pressure ulceration. Immobility. The normal person changes their position frequently, even when sleeping, because of sensory motor feedback system, and results in relief of pressure effects. In patients who are neurologically compromised or those with prolonged anesthesia or sedated patients, the body fails to make postural adjustments in response to prolonged pressure and ischemia. So then there's neurological factors. Neurological conditions causing paralysis or motor weakness prevents change of posture when pressure is exerted. The sensation of pain and pressure prevents prolonged pressure and therefore the ischemia. So plan, quality variance. Ideally, an acceptable incidence rates for all settings should be less than 2%. Reality is that in long-term facilities, reported incidents are between 2.2 and 23.9%. Home care is between 0 and 17%, and acute care is 59.2%. Pretty high. So root cause analysis, staffing, communication, education, training. So staffing, is there enough staffing, a staff available to help or be of resource? Communication, is there a right communication between physician, nurses, and student and nursing aides? With respects to the patient risk for pressure ulcer development. Education training, was the department staff involved educated in pressure ulcer prevention and management? Medical comorbidities risk assessment, are they incontinent? Do they have peripheral vascular disease? Are they septic? Are they have low blood pressure? Are they in multi-organ failure trauma? Do they have chronic inflammatory or catabolic state? Do they have history of multiple episodes of acute illness, which require frequent hospitalizations? History of pressure ulcers, glycemic control of diabetes, body weight or malnutrition, either if they're too heavy or not enough. So entry department, so patient initial entry department, are they a direct admission to a patient room? Did they go through the emergency department and then a patient room? So time until support surface therapy is initiated, when they were started to get repositioned, when it started to get documented. Did they receive any radiological procedures that they may have been in one position for a long time? Was the Braden score done? Does the staff is educated on how to properly score for at-risk patients? Repositioning, is the head of bed less than 30 degrees, greater than 30 degrees unless medically indicated otherwise? Are their heels floated or a heels offloaded device utilized? Shear reduction, has shear been reduced? Are they being turned every 2 hours? If they're in a chair, are they being offloaded every hour? Is their bed linen kept to a minimum? Incontinent pad fibers backed and not plastic backed. And immobility, are injuries limiting repositioning? Do injuries require surgery, restraints, surgical procedures? This one's a pretty important one. So number of procedures, pre-operative holding time, procedure duration, how long were they on the table for, what pressure relieving options were used, how long were they in recovery, was the recovery care service clinically appropriate? Okay, so plan, so the stakeholders, so nurses and nursing assistants, their bedside frontline staff who are vital to making changes in practice will have to take effect and will have to adapt to a new daily routine in order to prevent HAPUs. The lift team, They are key in keeping patients turned and moved every 2 hours. Not only are they extra help to nurses and nursing aides, but they also can assist as a team to turn the patient, also check with nursing staff to keep everyone on track with patient turns. Unit managers, they can support and encourage staff to continue with changes and new standards of care, assure that staff are following new guidelines and are accountable. The patients and family members are also very important. They're involved in patient care and assist in encouraging the patient to reposition or assist themselves in repositioning the patient if the patient is unable to do so. It's as simple as like being able to take a pillow out if they've been in that position for a long time. And the organization, they can analyze and eliminate root causes to the creation of pressure ulcers. And they can support all staff with resources, tools, education, and training to prevent HAPUs. Oh, sorry. Okay, the solution. So risk assessment. Consider bedfast and chair-fast individuals to be at risk for development of pressure injury. Use a structured risk assessment such as the Braden scale to identify individuals at risk for pressure injury as soon as possible, but within 8 hours after admission. Refine assessment by adding fragile skin, existing pressure injury of any stage, including those ulcers that have healed or are closed, impairments in blood flow to the extremities from vascular disease, diabetes, or tobacco use, pain in areas of the body exposed to pressure. Repeat the risk assessment at regular intervals and with any change in condition, base the frequency or regular assessments on acuity levels. And acute care should be every shift, in home care at every nurse's visit, long-term care weekly for 4 weeks and quarterly. Develop a plan of care based on the areas of risk rather than on the total risk assessment score. For example, if the risk stems from immobility, address turning, repositioning, and the support surface. If the risk is from malnutrition, address those problems. Education, teach the individual and family about risk for pressure injury, engage individual and family in risk reduction interventions. Skincare is a big, inspect all of the skin upon admission as soon as possible, but within 8 hours. Inspect the skin at least daily for signs of pressure injury, especially non-blanch or erythema. Assess pressure points such as the sacrum, coccyx, buttocks, heels, ischium, trochanters, elbows, and beneath medical devices. When inspecting darkly pigmented skin, look for changes in skin tone, skin temperature, and tissue consistency compared to adjacent skin. Moistening the skin assists in identifying changes in color. Cleanse the skin properly after episodes of incontinence. Use skin cleansers or pH balance for the skin. Use skin moisturizer daily on dry skin. And avoid positioning an individual on area of erythema or pressure injury. So repositioning and mobilization. Turn and reposition all individuals at risk for pressure injury unless contraindicated due to medical condition or medical treatment. Choose a frequency for turning based on the support surface in use, the tolerance of skin for pressure, and the individual's preference. Consider lengthening the turning schedule during the night to allow for uninterrupted sleep. Turn the individual into a 30-degree side-lying position and use your hand to determine if the sacrum is off the bed. Avoid positioning the individual on body areas with pressure injury. Use a pressure redistribution chair cushion for individuals sitting in chairs or wheelchairs. Ensure that the heels are free from the bed. Consider the level of immobility, exposure to shear, skin moisture, perfusion, body size, and weight of the individual when choosing a support surface. Continue to reposition an individual when placed on any support surface. Use a breathable incontinence pad when using microclimate management surfaces. If the individual cannot be moved or is positioned with the head of bed elevated over 30 degrees, place a polyurethane foam dressing on the sacrum. We usually use some called Mepalexes. I'm sure you guys know of those. Use heel offloading devices or polyurethane foam dressings on individuals at high risk for heel ulcers. Place thin foam or breathing dressings under medical devices. So implementing the solution. For nursing staff, being on a med-surg telemetry unit, nurses and nursing assistants are the first ones to get eyes on the patient once they arrive to the floor. To prevent any missed wounds or pressure ulcers on admission, a 2-nurse skin check will be performed and will be signed off by each as completed. Skin checks and photos uploaded to chart must be done within 8 hours of patient arrival to the unit. After Braden assessment is done, implement intervention as needed. If score is greater than or equal to 18, patient should be turned every 2 hours. If upon assessment, patient has pressure ulcers or complex wound, in addition to photos, wound care RN should be consulted for recommended care. This is to be accomplished by the RN. The lift team, in addition, if the patient will require turns, nursing staff is to place an hourglass-shaped magnet outside the room so lift team can round and know who needs turning if nursing staff is not available, and therefore the patient does not lose out on a turn. Charge nurse management, hold staff accountable, follow up with compliance. Study analysis. So work with the risk management, clinical nurse specialist, and unit management. Evaluate what happened that a pressure ulcer was missed, the amount of staffing that day, to nurse check if the 2-nurse skin checks assessment was done, what the patient's initial condition was, and patient risk factor assessments. Evaluate the effectiveness of implemented interventions and reassess what is working and what isn't. Are the amount of pressure ulcers decreasing from initiating new interventions? And keep a tally of how many days it has been since the last pressure ulcer. Action. Next step. After 3 months of implementing new intervention guidelines, compare the results of past 3 to 6 months. Continue with changes and reevaluate and compare with the last year's amount of HAPUs for the unit. The goal is that the amount of HAPUs decrease with current interventions, guidelines, and interdisciplinary teamwork. As recommended, occurrence should be down to 2%. If not, evaluate if staff is being compliant, if more training is needed, or classes need to be provided. And here are my references. Thank you for watching.